Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Welcome to the Going Antiviral podcast. Today, July 11, 2024, we are speaking to Dr. Paul Volberding, who is Professor Emeritus of Epidemiology and Biostatistics at the University of California School of Medicine. Dr. Volberding was trained in medical oncology, but quickly became involved in the early AIDS epidemic in San Francisco, based at San Francisco General Hospital. He has worked in clinical trials in HIV-related malignancies, and early in the epidemic, quickly became a pioneer in the development of antiretroviral therapy. He was PI and co-director, along with Warner Green, of the NIAID UCSF Gladstone Institute Center for AIDS Research, supporting the large community of HIV investigators in San Francisco. He is an active member of the National Academy of Medicine, of the National Academy of Sciences, and is a founding board chair of the International Antiviral Society USA. Today, Dr. Volberding is joining us to give us the latest information on long COVID disability guidelines, a topic that he was participating in as part of his National Academy of Medicine activities. So, Paul, welcome to the podcast.
Super to be here, Mike. Thanks. Happy to talk.
Okay, let's start with some basics because some of our audience may not know what long COVID is. It's sometimes called PASC or post-acute sequela of COVID. But what's all this going on with long COVID?
Right. So long COVID it actually is pretty difficult to define exactly because I think we're still learning about it. And in fact, the National Academy of Medicine had a second committee, in addition to one that I chaired, that was really focused directly on the definition. Long COVID is the term that I think we probably can settle on. There have been other ones, as you've mentioned, PASC and some others. But long COVID is a condition. It's a complex post-infectious condition. We can talk obviously more about it, but it affects many different organ systems, presents with many different symptoms. But typically it comes on after somebody has acute infection with SARS-CoV-2. Sometimes that initial infection is not apparent, but usually people remember it. And what happens then is that after a period of time, either right away or after a delay, people develop a variety of symptoms that are quite chronic.
And this can involve the brain, it can involve the lungs, the heart, the GI tract. Those are the predominant ones. And how would somebody know that they have it?
Well, good question, Mike. The number of symptoms that our study came up with at least 200 different symptoms that people might experience. People might have one or two. Some people might have very many. It can involve different organ systems. It can present in different clusters of symptoms. But common ones include, as you mentioned, kind of the mild cognitive problems, what is often been called brain fog, postural orthostatic tachycardia syndrome, which is another complex condition. People can have problems with really any organ system, shortness of breath, cardiac manifestations, neurologic manifestations. It really all depends.
Yeah. And fatigue seems to be a major part of this in most of the presentations, right?
Fatigue is a really common problem, and there's a condition where people get feeling really ill after any kind of exertion, post-exertional conditions that can be really troublesome and quite not exactly unique to long COVID, but quite common in long COVID.
So, as I mentioned in the introduction, you were heavily involved in AIDS at the outset in the early 1980s when it was a syndrome. There wasn't a known cause. So, I'm sure some of this echoes to your earlier experiences with AIDS. What do you see as different about this than compared to AIDS back in the day?
Sure. It's a there are areas of resemblance, but there are many areas of really obvious difference. Uh, AIDS is a condition that comes on after a person has been infected with HIV, often for a number of years. Long COVID happens much more quickly than that. HIV is a very difficult virus to transmit. SARS-CoV-2 is very easy to transmit. Um, HIV affects really specific subpopulations at higher degrees than others, whereas SARS-CoV-2 is an infection that, as we all know from having lived through the pandemic, can affect literally anyone. And so it's different in that regard. Also, HIV causes problems, causes symptoms, actually causes death in essentially everyone that becomes infected. While SARS-CoV-2, in most cases, comes and goes. People are left even without long COVID. So they're similar in some respects. They're both viruses, but they're different in many others.
So, when somebody has a case of COVID, are they more likely to develop long COVID if their initial disease is more severe, or can it happen even if somebody just had a mild case?
Well, both of those conditions can happen, Mike. People have a higher risk of long COVID if their initial infection with SARS-CoV-2 was more severe, especially if they required hospitalization or intensive care. And we're talking here especially about people in the early phase of the pandemic back in 2020. Um, but long COVID can affect even people that were mildly symptomatic or in some cases even asymptomatic infection. And because mild cases of SARS-CoV-2 are much more common than severe ones. In fact, most people with long COVID have a history of mild or asymptomatic SARS-CoV-2 infection. But it is more common in people who have a more severe initial infection.
And I'm sure one of the things your panel delved into was the notion of, let's say somebody had a very severe case, was hospitalized on a ventilator for a period of time, and then they survive and they come out. And anybody who's been on a ventilator, let's say for more than 2 to 3 weeks, could well have long term scarring of the lung, and that would have chronic uh, respiratory issues. How did you all parse that situation from what you might call long COVID?
Well, good question. And in fact, long COVID can resemble many other chronic complex conditions, including the post ventilator syndrome that people without SARS-CoV-2 infection, people that have been so sick, with pneumonia or some other problem where they've been on a ventilator, especially for a long period of time, they in many cases have lingering chronic conditions after that. And some of those symptoms can resemble those of long COVID. So it's really hard to separate out. But at the end of the day, long COVID is a pretty recognizable group of problems. And so I think it is possible to, in most cases, again, sort out and be pretty confident that you're finding long COVID in persons, even those who have been in an ICU and on a ventilator.
Yeah, so I think that situation with a long-term ventilator support is the more the exception. The rule is generally somebody who's had a case, maybe not even hospitalized. And,
Exactly.
and the new definition, as I remember from the National Academy, was that it had to be at least 28 days after the end of the original acute episode. Is that the number that people agreed
Uh,
on?
Right, and there are. I think we can still expect some degree of change over time in the definitions that we're seeing. We want everyone to agree on a definition so that studies can be more precise about what the actual risk is and what the actual chances of recovery are. But I think most people are leaning to that definition at this point.
So your group focused a lot on the disability and
Right.
how that might kick in. But before we get there, I mean, you may not have talked about it much, but was there any discussion about the cause or what people thought might be involved in creating the symptoms that are observed?
Well, we had a great committee, pretty young people, people that are definitely very expert and focused just on this condition right now. And we had a lot of discussions about what we call the pathophysiology, the pathway between initial SARS-CoV-2 infection and long COVID might be. Truth is that there are a lot of speculations. One of the things that I think we pretty much agree on is that in many cases, inflammation is part of it. So, an inflammatory condition triggered by the initial viral infection seems to be a common pathway. Uh, but there are many other conditions that people talk about, whether it's direct viral damage to cells, whether it's microcoagulation clots that are triggered by the infection. Uh, some people find evidence that there might even be ongoing release of viral particles or components of viral particles that are continuing this damage. Um, it's really an important question, because if you talk about treatments, what you'd like to do is have a treatment that's designed specifically for the cause of the condition. Here we're kind of in the dark. We're like we were with HIV in the very early days of the epidemic, before we knew it was even causing it. Well, you can't have a very good treatment unless you have a cause, and I think we're
Right.
still searching for the cause.
And in that case, it was ongoing replication of HIV that we found out in 83 or 84. Took us a while longer to get the drugs. But here, that is one possibility. One of the things that I kind of think about as a way forward as we analyze this is that usually after we get an infection, the immune system responds, and then the central immune system uh, generals, if you will, send out a stand down order, and the immune system says, "Okay, I'm going back home now, and I'll keep an eye for this coming back, but I'm not going to fight the fight. The war's
Right,
over."
right.
But it seems like that stand down order doesn't fully get received, and there's this kind of ongoing churn. But yet, people have tried steroids and immunosuppressive therapy, and it doesn't seem to work, at least not universally.
Well, inflammation is a part of what's going on here. I believe, but it's different in everyone. It's some people have more inflammation than others. I'm not sure it correlates that well with the degree of functional problems that are triggered by long COVID. Um, Clinical trials are really still getting organized. I don't think that there have been any definitive trials of anti-inflammatories, but you're right. So far, there's not much evidence that has turned things around quickly.
Yeah.
So I think we're still to some degree in the dark in terms of where we might go with treatment.
Right, and there are ongoing clinical trials. And full disclosure, I'm on the data safety manager monitoring board of the Recover study, which is looking at a wide array of long COVID symptoms and different interventions. And as you indicate, the approach to treatment is mostly symptomatic at this point. There are a couple of concepts looking at the notion of maybe there is ongoing viral replication using antiviral drugs, but it does remind me a bit of the early days of AIDS when we saw something happening and we weren't certain of what was going on, and we were kind of flailing at it. Your colleague at San Francisco, General Maury Shamblin, was quoting all the time Buffalo Springfield and saying, "There's something happening here. What it is ain't exactly clear." And so,
Most of the audience of this podcast will not know what you're talking about,
yeah,
Mike, but
yeah,
I do.
19, so Stephen Stills,
Right,
Buffalo
right.
Springfield,
Yeah.
right. So moving forward a little bit, when this happens, how long does a person suffer on average with this disorder? Because that would relate to the disability issues you were exploring.
Right, right. So, Social Security Administration is really focused on people that have long-term functional impairments, people that really can't work for a long period of time, and those are the people that SSA is really focused on helping, including students that, in these cases, can't attend to school. Um, so, this can be a chronic condition. It can go on for certainly weeks, often months, and probably years. We don't yet know because we haven't been following it long enough to know uh, how often it will resolve enough to allow persons to go back to their normal lives. Um, and that's some of the data that Recover, as you mentioned, in other studies are collecting. We're going to be watching those very carefully. But it is a chronic condition. I would also toss in that there are other similar chronic conditions, chronic fatigue syndrome, and others that we've known about for a long time. They're similarly complicated, very troublesome, and again, very hard to approach in terms of treatment.
Yeah, the one that immediately pops into mind is the so-called chronic Lyme disease, which is just embedded in controversy because some people say that it is does seem to be a major cause of disability, but what to do about it and whether you
Yep,
give
yep.
long-term antibiotics, which has been refuted pretty fully, but yet some docs still lock in on that and try to treat it. But it sounds very similar in its presentation, and maybe we'll find out one day that it's very similar in pathogenesis, and that would be fascinating.
No, I think what we're beginning to realize is that probably a variety of infectious conditions can trigger this unusual reaction, an adverse reaction in the part of the body, especially the immune system, um, instead of uh, causing a flare and then a relaxation of the immune response can trigger long term problems, and Lyme disease is probably one of those.
So I'd like to take advantage of your long experience with the National Academy of Medicine, and you mentioned you chaired this. So, how'd you all go about the process of coming up with recommendations? But and I guess finish with what the recommendations are to insurance and to SSI at the end of the day, which you all said that should be the considerations.
Right. Good question. And there's a very formal process by which the National Academies develops um, these committees commissioned by the SSA, in this case, Social Security Administration. SSA approached the academies with a question. We want to learn more about long COVID. We're concerned that we might be seeing a lot of cases come to us. We want to know how we might better respond to this challenge. Then the academies puts together a committee. There's a chair. I was the chair in this case, but they appoint members where we try to reflect the diversity of the country, of the condition. In this case, we had people involved in neuropsychology, people in pediatrics, people in adult medicine, people in rehab medicine, and others, so that after deliberations, and the process can take a year and a half or more, multiple meetings. We invite outside speakers. We invite outside reports to be presented. We invited people with this condition, long COVID, to talk to us about their problems. And we then generate a report. The academies have excellent staff members who have been experienced with other reports that help the committee develop the response. There's a very specific statement of task from the sponsoring agency, in this case, again, the Social Security Administration. And so they asked us very specific questions. We respond with a report that addresses those questions. They didn't so much ask us for direct recommendations on what they should do, but rather they asked us to help better inform their process so that as they kind of grapple with this, they can, I think, do the right thing.
Yeah, and I guess the end of the day, a disability is a disability. It's interfering with their ability to function, and that assessment would be done, I suspect, for this condition as any other, just to evaluate how much of their usual work they can do, or what they're limited to, and then the SSA can respond. But it does make sense that they would want to know more, and it sounds like your group did a great job of answering or providing some reference to them.
I
Um,
hope so. Yeah.
yeah. So let's getting practical. Let's say someone listening is feels like they've got long COVID, where, I mean, they can go to their initially to their local physician or provider, and they'll probably get a sympathetic ear, but uh, they're they might not have any direct experience on how to manage this. So, how can somebody go about getting to a specialty center or doctors who are really focused on this?
Well, excellent question, and not an easy one. This is by definition, it's a complex condition, and it's a condition about which many healthcare providers know very little, have had very little experience. And yet it's a condition that really almost demands a complicated team of professionals in response. It's really great if you can have either an adult or a pediatric primary care provider, but also neurology and cardiology, depending on the problems that the person is having. There are some dedicated complex long COVID clinics across the country. Um, there aren't enough of them, and the demographics of this disease. If you're in a rural area, it might be very difficult to find that level of expertise. I'd start with your primary care provider, obviously, but there are a lot of resources online. I think these days most people turn online almost as a first pass, and you're likely to find people that are knowledgeable. Whether or not it's going to be easy to find them and to get an appointment, it's another challenge. And I'm sorry to say that it's a really common challenge for people. But keep at it. Again, it's a chronic condition. It's real. Don't let anyone tell you it's all just kind of in your head. It's a real and complicated condition, and I think everyone deserves the best coordinated care that they can as they think about what the impact is going to be on the rest of their lives.
One of the things we didn't talk about, I want to make sure we get out, is that the incidence of this or prevalence is about 8% or so, right? It varies 6 to 12%, depending
Right.
on where you read.
It depends on your definition, depends on when you're looking, and a lot of other factors. I think it's fair to say that long COVID was triggered more commonly in the early phase of the pandemic, before we had vaccines, before we had treatments, both of which we think can help reduce the either the magnitude or of the problem or the duration of it. Um, and it seems as though it was triggered more again by severe acute infection, and that seems to be more common with the people back in the day with the Omicron variant, but it's still happening now, and so you just have to be aware of this. And as we're talking today, Mike, there's another surge happening across the country of COVID infection. So this will continue to be a problem.
Yeah, and we talked to Peter Chin Hong about that earlier today, about the surge in current COVID
Yep.
cases. The other thing that I think fits with what you just said is that it appears to be less common among those who are vaccinated or have some degree of immunity. So maybe that's the common thread and why early on we saw more of it, because people hadn't, their immune system hadn't seen this virus before. And then if they got vaccinated before they got their episode of SARS-CoV-2, they may have been somewhat protected against whatever it is that causes long COVID. Um, any final thoughts where you think this is all heading after you've finished your work with the committee? Your best estimate of what we're likely to see in the future?
Sure. So I think that it was an incredible opportunity to be involved in this in this process. It's a serious problem. It's a growing problem in the country. I think the opportunity is really to force us to once and for all kind of deal with these complex post-infectious chronic conditions. Uh, you know, uh, Chronic fatigue is a real issue. Chronic Lyme is a real issue, and there are others, and likely that they have some common pathways, and that if we can find, the direction of one in terms of cause and treatment, the hope that we might be able to apply that kind of knowledge to others should give us a real hope. But in the meantime, as we've been talking, we have a serious problem on our hands.
Yeah, we do. Maybe we'll get some AI algorithm that'll help us through it. No kidding.
Holding my breath. Yeah.
Well, Paul, thank you for joining the podcast today. It's a fascinating story that affects a lot of people, and hopefully we'll have some answers very soon. But your comments were lucid and on point and very helpful in a short amount of time. So thanks for your time today.
Great to be with you, Mike. Thanks a lot.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.